Hello, this is Dr. Jeffrey Miller from Baltimore, Maryland. My topic is how to use the alveolar housing anatomy to more properly position the incisor roots. My name is Jeffrey Miller. I graduated from Towson University, received my dental education from University of Maryland, my certificate in orthodontics from SUNY Buffalo, my board certification in 1991. I've been in private practice in orthodontics in Maryland for almost 35 years now, and I'm a member of the Golden Circle of Excellence through 3M. I also speak on cone beam CT topics related to orthodontics. When we talk about using the alveolar housing anatomy to more properly position the roots of the incisors, I think that would make sense to just compare it to a cephalometric and panoramic image. Here we have a patient that's 5 years post-active orthodontic treatment. If you were to look at the reconstructed pan and ceph, these images are reconstructed from the cone beam CT. Obviously, the cephalometric reconstruction is taken out of occlusion. There are reasons for that, but they are not germane to this talk. If we were to take a look at the lower left lateral incisor, is there any indication that there's a problem with that tooth based on a pan and cephalometric analysis? And I would defy you to find something wrong with that incisor based on these two images. However, if you look at it from a cone beam CT perspective, you can see that that incisor clearly sits outside of the alveolar housing. It's the ability to look at individual teeth and their alveolar housing that I believe is really a game changer or innovation for orthodontics and cone beam CT. Cone beam CT provides a lot of information. People in our profession are using it for a lot of different things, but when it comes down to it, cone beam CT can provide information about the root and the anatomy of the alveolar housing that really is not available from any other radiological source. If you take a look at these three patients, all three need retraction of the upper incisors with vastly different alveolar housing anatomy. The patient on the far left has a much more limited alveolar housing compared to the patient on the far right. So should that be a consideration when retracting these incisors? I believe so, and I believe it's an important consideration for orthodontists. Here we have two patients, these are lower central incisors, and you can see the alveolar housings are quite different. The one on the left is much more robust than the patient on the right. Same thing from an axial view. Here's a patient with minor crowding of the lower incisors. This is an axial view taken halfway down the length of the root, and you can see this clefting of the bone associated with the two central incisors. Bringing those central incisors forward may cause dehiscence in the cortical plate, and knowing that information I think is important for anyone moving teeth orthodontically, whether it's through aligners or fixed appliances. This is a case that was transferred to us by another orthodontist. These are the pre-treatment orthodontic records. She, I would say, is Class 1 on the right, more end-to-end. Class 2 on the left, deep overbite, mandibular asymmetry. He treated her with a herpes appliance to correct the Class 2. Here is the cephalometric x-ray of this patient pre-treatment, and you could see that, she is really not that bad. Certainly not as bad as many of our Class 2 patients. Here's what it looked like when I first saw her. These are the diagnostic records we took. You can see that both sides are Class 1 now, and get an idea. These photos were taken right after I removed the herpes appliance. As far as profile change, I really don't see any significant profile change between the pre-treatment and the post-herpes appliance treatment. Maybe her lower lip came forward a little bit, but I don't believe there's any change in the position of her mandible. So how was the correction achieved? I took the cone beam and I superimposed the alveolar base of the lower incisor. to give you just kind of an idea of how correction was achieved. So it was mostly achieved by the proclination of the lower incisor. When you look at the individual slice, this is tooth number 24, you might have a tendency to clinically want to upright the root or put labial root torque on that incisor. But based on the knowing the anatomy of the alveolar housing, bringing that apex of that root forward would cause the root to possibly dehisce even further through the facial cortical plate of the alveolar housing of that lower incisor. This is just another case with a class 2 skeletal but a class 1 dental relationship. This is a reconstruction that you can simulate treatment with, and it's a similar situation, although here this patient had never had treatment. So knowing that the anatomy of this alveolar housing is very thin, bringing this root forward or labial root torque would cause the tooth to dehisce through the limit of the facial cortical plate, and you probably end up with something like that. But to know that information, you have to first be able to visualize it, and I don't believe a cephalometric x-ray is adequate to visualize this information. What does that look like in real life? It probably looked like something like this. A colleague sent this, and in this case was expanded, and then the incisor was torqued, and you can see how that incisor is pushed outside of the limit of the alveolar housing. So what do you do about it? How is it repaired? The earlier case I showed you where the young man, that his lower incisor actually was torqued outside the limit of the alveolar housing, he developed a habit of chewing on plastic water bottle caps. This is, if you can see here, he has a lower fixed retainer. It's still intact. Why it didn't break, I have no idea. But he chewed on plastic water caps, and he caused torques on his lower left lateral incisor as well as torques in the opposite direction on the lower right lateral incisor. So once you know this information, then it's fairly easy to figure out how much torque you need on that tooth. This is a line, I used lingual appliances, and this line represents the long axis of the tooth, and it intersects the center of the bracket slot. The bracket slot's on the lingual because these are lingual brackets. Then you draw another line that comports with the center of the anatomy of the alveolar housing. And that angle that's created is the amount of degrees you need to correct the position of that root. And that's with fixed appliances. If the bracket was on the labial, this line would just go through the slot on the labial. What about aligners? Very similar. If you take with aligners, you run through the center of the clinical crown. Not sure how predictable torques are using aligners, but if you were to use aligners, at least an attempt to get the tooth recaptured into the alveolar housing would be in the right direction. Keep in mind that when these teeth are set up by the aligner companies, they're only looking at the clinical crowns, and there's no consideration for the alveolar bone or the root. So what does that recapture look like? Here is that same patient. He came in 5 years post-active orthodontic treatment. His dentist sent him back to us because of the appearance of the gingiva, the blanching of the gingiva associated with the lower left lateral incisor. And as I said, the lower right lateral incisor was being torqued in exactly the opposite direction. I used a lingual appliance where I could specify exactly how much torque that was needed to get the tooth to back over the bulk of the housing. And the first wire, this is the day we placed the brackets, was a 1725 TMA. So the torque is actually in these brackets, and these, in theory, these two torques should cancel each other out. This was 3, and this was 3 degrees in the opposite direction. This is what it looked like 6 months later. You can see the tissue is not blanched anymore. He wasn't a very compliant patient. He disappeared for about 6 months. So 1 year after we replaced the brackets, he came back, we took a cone beam, and you can see how the incisor was realigned to comport with the alveolar housing. And you can kind of see this here a little bigger, and how that lines up much better. So in summary, I think that it's important for orthodontists to consider the anatomy of the alveolar housing and the root position when both treatment planning cases as well as evaluating the finished results. Thanks very much for listening. If you have any questions, you can contact me at drmiller@orthodonticassociates.com. Thank you very much.